guys. Well, thanks for having me. I know you guys have been focusing on OCD the past few weeks, so we're going to continue with that and talk about contamination OCD. Contamination OCD is a subtype of OCD where someone experiences intense fear or distress about contamination. And it might refer to people being afraid of dirt or germs, but it can also stem from things that they just even perceive to be harmful, toxic, or impure. So it might not be something that other people or everybody might think is gross. Individuals may also experience mental contamination when they come in contact with impure people or objects. And then some people with contamination OCD might fear a specific consequence, such as getting sick or spreading harm to others. But there is a large subset of people with this that also, there's no fear of actually getting sick or of any danger or anything bad happening, but they actually experience intense feelings of disgust without a specific consequence. And I think this is an important distinction because treatment is going to look the same, but individuals with disgust OCD don't necessarily habituate in the same manner as people who are just afraid of getting sick. So while the exposures might look the same, the goal differs a little bit. So disgust OCD. Disgust is a basic human emotion that is supposed to protect us from harm. So everybody does experience it, but for people with disgust OCD, the emotion becomes more overactive, and then contamination is perceived when there's no danger. The main emotional trigger in disgust is disgust rather than fear or anxiety. And so in classic OCD, that often centers on anxiety about harm or danger, but disgust is really just involving intrusive thoughts, images, or sensations that just evoke intense feelings of contamination, impurity, or moral revulsion. These people don't experience feelings of danger, rather they just feel a sense of being contaminated physically, mentally, or even morally. So if you ask them, okay, well, what's the worst that's going to happen if you touch that doorknob? They're not going to say, oh, I'm going to get sick and die. They're going to say, I just feel gross, or it just feels disgusting. And sometimes it's hard to really get at any real consequence. It's just a feeling of being disgusted and then never being able to get rid of that feeling. And so they might also just avoid people who seem unclean, and in addition to places. So, I have a client who will walk on opposite sides of the street from homeless people, from people carrying McDonald's bags, because the grease is disgusting. So if she even sees McDonald's or a McDonald's bag, she's avoiding that. And again, it's not because she's afraid of getting sick or anything like that. It's just feeling that it's just gross and dirty. So in disgust OCD, there are common themes of contamination, which is just feeling dirty and avoiding people or places that seem unclean. There could be moral or sexual disgust, which is related to sexual or violent intrusive thoughts, or contamination by bad thoughts or actions. So even just thinking something could make them feel really disgusted and uncomfortable. There could be symmetry or body-based disgust, where it's related to their different parts of their body or appearance that might seem deformed or asymmetrical, or they might even just feel uncomfortable with their own feelings or sensations. And then there's mental contamination, where it's related to associations with specific ideas or memories, and so they might try to avoid any reminders of these associations. So not just with respect to disgust OCD, but just contamination in general. What do you think some of these obsessions might look like? Yeah. Ideas.
You guys are welcome to put it in the chat. You can certainly raise your hands as well. Give it a minute, everybody, to participate.
Michelle?
Maybe for obsessions with contamination, it's like if I touch this doorknob, I'm I'm going to feel it on my hand all the time. I just got off a call with that client and that's what she said. She was in a hotel and she said she's like, I just kept thinking my hand touched a doorknob and now I'm going to be sick. And now like, she just couldn't get the idea, like to the point where she said she felt like her hand almost vibrating with contamination.
Yeah. God. Yeah. And did she engage in any compulsion or anything? Did washing it or anything help, or did that not even help?
She said they were at a hotel, so she went and got in the pool because they were on their way to the pool. And she's like, the chlorine was disinfecting my body. The chlorine was disinfecting my body. And then she said she was able to resist getting into the pool longer the second time, and she didn't wear gloves. I guess usually in a hotel she wears gloves, like rubber gloves, the entire time.
Okay. Yeah, so it's interesting how in those moments too, the OCD tries to find ways. Okay, it's almost like a kind of negotiating with yourself, right? Like I feel really dirty, but maybe if I go in the pool, that'll get rid of it. Or I'll, just trying to find a way to make herself feel better in that moment. So that makes sense. But it's good that she was able to try to expose herself too by not wearing gloves. So thanks. All right, Ty.
Yeah, so I actually have a child client who has celiac disease. So she is afraid of getting sick from gluten. So she is afraid of like anything being contaminated with gluten. So right now she won't like eat off of plates or bowls or utensils at home. For the longest time, she wasn't eating with her hands because she thought all of it was contaminated with gluten. And so she only eats, and she also has ARFID, so we're like working through that as well. But she only eats certain foods that are packaged. Only she can open them, or her parents. She won't eat dishes off of dishes out of the dishwasher, especially if her brother put the dishes in there. So there's like a lot of just intricate things there. Like even in our office, she won't play with Play-Doh because it has weed in it. And she fears that it's contaminated with gluten, so she's always like applying hand sanitizer. We tried to delay that in session, but she ran and got it and would refuse to not sanitize her hands. So yeah, there's complexity of that disease, that medical condition with her contamination OCD.
Yeah. Well, that's really interesting because it's hard because there is some risk involved. So it's not totally irrational at all, because obviously she has probably experienced really negative consequences from coming into contact with gluten. So she does have that evidence that it can be dangerous, but then it's kind of spiraled into, that, everything is contaminated. And so, and I've worked with people too who have peanut allergies and things like that in similar ways. And it is really difficult. And also so it's like with that too, trying to also consult with professionals, with doctors and things like that, just to make sure, right? Like, okay, what can we do? What can't we do? And then sometimes that, so then you can feel comfortable moving forward with that. And then sometimes them having that permission can help. Although sometimes, again, with the OCD, it doesn't matter. Even if 1,000 people tell them it's fine, it's still that small doubt that will make them avoid. But that's a really interesting case. But it sounds like you're doing a great job trying to expose her and work with her and just kind of meeting her where she is. So, yeah, thanks. Miranda?
Yeah, I was thinking of a client who has emetophobia, and actually the other day in session we were talking about an exposure and walking. She'll avoid hallways, but it's more that like she's afraid of that feeling of disgust, or that she's going to be contaminated by the throw up. And she said that she would walk over it and then she would like get rid of her shoes, which I thought was really interesting. So she said, I will do it, except then like I won't wear the shoes for a few months, or I'll have to wipe them down or clean them and make sure that they're not, because then I think she used the word contaminated. And then she mentioned, also not related to emetophobia, that she still has a pair of pants that she hasn't worn because she wore them to a funeral, and that like they were contaminated because of that memory. So it's more like emotional contamination. And I asked her how long ago the funeral was, and she said it was 2 years ago, and she still hasn't worn the pants. So yeah, that was kind of making me think. So there's a lot of avoidance and also, yeah, like cleaning, making sure she's clean, a lot of reassurance seeking. So like, are my shoes contaminated? Are they going to make me sick? Things like that.
Yeah. Oh, that right. So she's got all of it. She's got the right, the avoidance and of certain things, but then there's also like that mental component too, where it's like that exactly kind of what we were talking about with the, that the memory of it. So trying to avoid anything associated with the memory. But if you really ask like what is it that you're afraid of, it's just more of probably feeling uncomfortable versus like any specific fear of anything bad happening. So yeah. Thanks. Hallie?
One thing that I've seen that's like pretty common across contamination, this is such a hard thing to say.
I know.
Contamination OCD clients is just like an overall avoidance and like very intense fear of like public, like multi-use places. So like buses, the train, like public gyms, like gym equipment, and like even like restaurants, like the forks and like the knives and the silverware and stuff, like because it's been used, those are things that have been used by so many people. Like there's this idea that they have that those things will never truly like be clean. And so it kind of equates to an avoidance of like places like that altogether. And I've like even had clients before, like they'll bring their own silverware or like dishware to like restaurants and things like that, just because there's this idea that those things will just never be clean.
Yeah. And it doesn't help that there's always these articles that are like, what's more disgusting than, and then they, everything you think is disgusting. And they're like, actually, this is worse. And then they start giving breakdowns of the germs and everything that they found on all these different places. So, and that is just readily available to all of us all the time. So it makes you, if you weren't afraid of it before, then it's like, oh, I should probably add this to my list. So, yeah. Well, thank you guys. Those are all really great, examples. So just, yeah. So just kind of running through, I think you guys covered a lot of these, but fear of catching an illness, worry that objects or certain environments are dirty. And then there's sometimes too, it's not even necessarily a fear of getting sick themselves, but more of this kind of, it links to harm OCD of being afraid that they're going to cause harm or death to others by spreading something. And then feeling contaminated after touching specific items or people. And then also this, one of my very first OCD cases, there was a fear of becoming like a person that just sat in the chair or touched the item. So this person would, if they didn't want to sit in a chair of somebody that they didn't like or had characteristics that they didn't like, because they thought that this magical thinking, if they just sat in that chair, they were going to become like that person. So that was interesting too. And then compulsions, and I think you guys, when you talked about obsessions, you guys brought up a lot of those too, so we can just go through these quickly. But there's the excessive hand washing or showering, avoiding touching certain objects or people, or bringing, kind of rubber gloves places, cleaning or disinfecting items repeatedly, changing clothes frequently or avoiding certain areas. Like I have someone I'll talk about later who has like airplane clothes or bus pants, or what you think about, I don't know, Big Bang Theory, he had his bus pants. So people have their certain outfits for that too. Mentally repeating phrases or prayers for protection. So that's when maybe there's nothing physical you can do, but okay, if I can just repeat something in my head over and over again, it's going to have the same effect of getting rid of that contamination. Avoiding specific public places, bathrooms, or physical contact with others, or throwing away, or like Miranda said too, not wearing something maybe for 2 years that could be contaminated. So just in terms of outcome measures and diagnosing, using the Y box or the CY box for kids, which we have readily available, the OCIR, also there's the washing subscale that you can use. There are more specific contamination measures that go into more detail that are mainly used in research, like the Padua or the Vancouver Obsessional Compulsive Inventory. And then also just, when going through the Y box, really just asking more about what are the feared consequences to try to get at more of those just right feelings of disgust, instead of just the assumption that, okay, if I it's a fear of getting sick. And then just the DSM diagnosis, the presence of obsessions or compulsions. Obsessions or compulsions are not caused by substance or other medical conditions. They do cause clinical significant distress or impairment, and they're not better explained by another mental disorder. Just the cycle of OCD. So here, a thought of a fear of germs or of something being contaminated, which leads to feeling uncomfortable or anxious. And so the compulsion could be washing hands repeatedly, or maybe jumping in the pool, or even just repeating something in their mind over and over again. And then this provides temporary relief, but then, as we all know, it just starts all over again the next time they have that same thought or encounter that same situation. So here is just trying to look at the difference between just contamination like fear-based OCD and disgust-based. So in fear-based OCD, again, there's that fear, I'm going to get sick or something bad's going to happen. But in disgust-based, it's really just, it feels gross or dirty. They really can't explain anything else other than just, it's just going to feel this way forever. Then the anticipated consequence is that something, harmful is going to happen, or they're going to get sick, or, contaminate others. But in disgust space, it's just, I'm going to feel gross or impure internally. And I think too, it's also kind of sometimes this fear that once something gets contaminated, I'm never going to be able to get it clean. And then if it touches something else, then it's just going to infiltrate everything, and that they're just never going to feel clean again. The incentive for the compulsion in fear-based OCD is to avoid any harm, illness, or danger. In disgust-based, it's just trying to get rid of that feeling of discomfort. And this is where a big difference happens, is that in fear-based, the anxiety is going to increase and then peak and then decrease over time once they kind of sit with that discomfort, or they can't touch the doorknob or engage in any of their cleaning compulsions. Over time, they see, okay, I'm not getting sick. The bad consequence isn't happening. So they really can learn from that. But with disgust, it's just going to persist, because they're never going to see, oh, okay, I never feel disgusted again. It's over time, it's just going to start to fade a little bit, but they're never going to necessarily habituate to the feeling of disgust, especially since it is a normal human emotion that we're all going to experience. And sometimes we need to experience that for our own safety. So they're never going to be able to get rid of disgust. So it's just kind of more learning to sit with it and have it be less important, but it's not going to just go away. So treatment strategies, there's obviously the best way to treat this is to have them engage in exposure and response prevention. So building a hierarchy, rating their SUDs, and then gradually exposing them to triggers to reduce the rituals or safety behaviors. Can also do imaginal exposures if there are certain things that you can't really get at physically. When it's driven by fear, then the exposure is going to kind of teach them that nothing bad happens and that feared consequence never occurs. Or even sometimes, though, maybe they will get sick, not necessarily because they touched the doorknob or whatever it is, but just coincidentally, because sometimes people are going to get sick, but they might kind of learn that, okay, it's not as bad as I thought, or I can handle it. So we're never getting that certainty that, okay, I can promise you that never engaging in these things, you're never going to get sick. But it's more of like, okay, if you do get sick, did you survive? Were you able to handle it? When it's more disgust driven, then the exposure is going to teach them that the level of distress and discomfort will decrease over time, and that you're not going to be thinking about it forever, and that you can handle it. And then we can use ACT to focus on accepting the uncomfortable feelings instead of trying to control them. And then a lot of times medication really can be helpful in conjunction with therapy. And the first line is usually SSRIs or SNRIs. And what studies have also shown is that with these medications, oftentimes higher doses need to be used to treat OCD. So while maybe, lower doses of Zoloft, for example, can be used for social anxiety or generalized anxiety, but a lot of times those with OCD have to go to a much higher dose in order to get any relief from that. And so that's why it is really important when people are having med consults to make sure that they're meeting with someone who really knows and understands OCD. And then sometimes when there's really treatment resistant OCD, or almost the obsessions kind of take on a more delusional type quality, sometimes atypical antipsychotics will be used in addition to the antidepressant. So, and then there's also inhibitory learning and tolerance in disgust-based OCD. So again, we're not trying to eliminate that disgust. You're just trying to teach them that, okay, I can feel this and not try to get rid of it. That disgust doesn't actually mean danger. Over time, the feelings will pass or become less relevant, and reduce the reactivity and increase tolerance rather than extinction. So just a little bit more detail in what this kind of looks like is, so just trying to establish rapport and then really give a lot of psychoeducation about OCD and ERP, and then identifying those obsessions and compulsions and gathering data, the baseline data, and then normalizing symptoms, explaining the OCD cycle, and then emphasize that treatment involves facing fears gradually and resisting rituals, and just reminding them too that, it's going to feel uncomfortable, and that's okay. Then just creating the exposure hierarchy, and it's going to be the same for individuals who have fear-based and disgust-based, because still having to engage in all of these behaviors that make them uncomfortable. But again, kind of just the long-term, what we're looking for is going to be a little bit different. And then in 3+, it's starting to do those exposures, preventing them from engaging in those behaviors. And I think starting to, like, I know some of you guys talked about delaying, which is, if we can't get them to fully not engage, then delaying is really helpful first, and then trying to work your way up to that. So we do want to begin with manageable exposures to promote success and confidence, but we also don't want to start with something so low that they don't learn from it. So we really want to try to find something that would be maybe around a 4 on the SUD scale. And then really encouraging in between sessions, doing whatever you guys worked on in session, because, it's the consistency that's going to help. So if they do it once with you and then they don't do it again until the next week, it's going to be starting all over again. And then really helping them remind themselves that, yep, this is uncomfortable and I can handle this, or, kind of what goes up must come down in terms of anxiety, and that it will go down even if I don't engage in this behavior. Relapse prevention and maintenance, just reinforcing the skills, creating a long-term plan for setbacks, reviewing progress. And I think just also kind of really trying to help generalize, because sometimes with OCD, if we're able to extinguish it, then it's going to try to come back again in a different form to try to catch people off guard. So just trying to help them understand that even if the obsession is different, that the feeling is still the same. It's if you're feeling like that, you have to do something, compelled to do something, recognizing that that's OCD and trying to apply the same things that they have learned before. Also normalizing intrusive thoughts. We're all going to have intrusive thoughts. And a lot of times with OCD and people without OCD, our thought content is the same. It's just the importance that we put on it. So a lot of people might experience thoughts about, ew, this is gross, but it's just what we do with it versus that, okay, because we think it's important. Anxiety reduction is not the goal. We're really just trying to tolerate the distress and be flexible. And then, might need kind of maintenance booster sessions as needed. Any questions so far? at all. I know I kind of ran through a lot of information, and I really wanted to try to highlight disgust-based versus fear-based, because I think more recently we see a lot of that disgust-based, and I think it's helpful to understand the differences. But any other questions so far or thoughts? Well, I'll start with case example number 1. That's Jane. So she is 39. She lives alone, but she's very close with her parents who live out of state, but close enough to come visit a lot. And interestingly, they each have their own OCD symptoms. So mom is a hoarder. Nobody can even go in the house. They have never been able to invite friends over. And actually it makes my client very uncomfortable to go there because it's so dusty and dirty and full of stuff. So now she won't even sleep over there anymore unless her mom makes some concessions. And then her dad has really interesting OCD tendencies where he won't, she's afraid he's going to get arrested at the airport one day soon because he flies all the time. He doesn't want anything going through security because he feels like there's some contamination that's going to happen. So he doesn't even bring his regular phone on the plane. He has his own separate airplane phone. And he argues when things have to go through the scanners at TSA. And almost to the point where my client, who has really severe OCD, feels embarrassed. And then the brother is completely the opposite. Like, he really kind of is not nice to her about her OCD. However, they all use gloves at the gas station, including him, and they all carry plastic bags on the airplane, like garbage bags, in their pockets, so that if they have to take off their jacket and put it through the scanner, they will put their jackets in that. And then if they have to put it in any of the compartments on the plane, they'll use the plastic bags for that. And while Jane understands that her behavior is more extreme than those, there's still some part of her that kind of feels like, well, why doesn't everybody do this? Like, she's like, why doesn't everybody carry plastic bags with them when they fly? Because everyone should want to keep their stuff clean. And while at times she does have some worry about getting sick, like she did wear masks during COVID, probably 2 years longer than everybody else, she mainly really just experiences intense feelings of disgust. So if you ask her what the worst case is, it's like, ew, it's just disgusting. So she worries that everything is gross and contaminated. If she touches something dirty and then touches something else, then it's just going to continue to contaminate everything around her, and she's never going to be able to get it clean again. So she works from home, and actually nobody has been in her apartment, including her family, since pre-COVID. So she's been able to kind of keep her apartment as this really safe space that nobody comes in, other than she has someone who cleans the apartment every 2 weeks, and then if maintenance has to come in, but that is really stressful for her. She has very complex rituals around washing and drying clothes, what comes into the apartment, the order that she does things. So like, she has to she can't touch her dirty clothes. If she's clean, she can't. And she's all these different rituals about like how she puts the stuff in the dryer. Her suitcases can't come past the front door. She just, her apartment is a total clean space. She has airplane outfits. She won't sit, or wouldn't sit, in medical waiting rooms. So she would just stand whenever she had to go wait someplace. Her credit card fell on the ground at the gas station, and she had a total meltdown, hysterically cried, calling her parents, had to go back to her parents' house and have them help her, because she didn't know what to do when the credit card touched the ground at the gas station. She ruined her phone by running it underwater twice once it fell on the ground. Just didn't feel clean enough, so she did it again and then ended up having to get a new phone. And so whenever something happens that's unexpected, in terms of contamination, she becomes almost paralyzed and doesn't know how to handle it. So I mean, treatment has included psychoeducation, exposures, reducing reassurance, because she calls her parents for reassurance all of the time. So, but just thinking about this, how, what would you guys do to try to reduce reassurance seeking? And then, oh, go ahead, Shal. Thanks.
I feel like I would first start by just trying to lengthen the time in between, like having the urge to reassurance seek and then actually asking someone. So not trying to extinguish that compulsion immediately, but sort of bridging that time. Because it sounds like that reassurance seeking is something she clings to, and I'd be afraid of almost like backfiring by like trying to extinguish it too quickly.
Yeah, no, that's a good point. Yeah, she because and that's right, because she calls her parents knowing though, and it's helpful for her that her dad has OCD, because then if he tells her, oh, it's okay, then she feels like, okay, well, if my dad would do it, or if he says it's okay, then it must be okay. And then her mom, yeah.
I find that
Go ahead.
dynamic so interesting with the parents with OCD and the child, and how that cycle in adulthood, not just when they're children, that it's sort of this interdependence of reassurance seeking. I'm fascinated by this.
Yes, it is so interesting. And then it's so, because then she'll say like how ridiculous her dad is, but but it's interesting because I mean her behaviors are really extreme as well. And then her mom will tell her, she's like, if you behave like this in public, no one's ever gonna, because she had a lot of problems dating and things like that. She's like, you're gonna look weird in public. This is why you're not dating anyone and things like that. But then her mom can't even have anybody in her own house because of the hoarding. So it's just so interesting how it's like they've all had their own OCD, but then they don't understand each other's sometimes. So, but then when it comes to reassurance seeking, they're her safety people. So yeah, I agree. And it's probably not even possible to eliminate it fully because she's also pretty lonely, and really some of the only people she talks to are her parents. And so if we cut them off for reassurance, it could also be kind of cutting off her kind of social interaction too. So yeah. And then interestingly, even though her mom fears that she probably looks weird in public and nobody wants to be around her, she actually, when she goes out in public, like she'll go to concerts, all day concerts, and she'll go on dates, and she'll go to other people's houses. And interestingly, when she's gone out on dates, she's gone back to guys' hotel rooms and will engage in, in behaviors with them too, despite her contamination. So in public, she actually looks really like she doesn't have OCD. So yeah, I guess any thoughts on why this could be, why it's like so severe at home, but then she's able to kind of hold it together outside? Emma?
Yeah, I mean, I think something that I've seen with clients in the past of like, for example, if she's like going back to people's hotel rooms, it's like, oh, well, it's not like my house. So if I get this dirty, like, then I get to leave. Or like if this feels contaminated, it's not like I'm staying here forever. It's more like this one-time thing. So it's like that kind of thought cycle of like, for some reason, it's like almost, it doesn't count. It's like not the same because it's like not her primary place, or like a place where she would have to go back to again.
Yeah, that's exactly, I think, what it is. It's like being somehow she's been able to, again, it's like this negotiation with herself. Like if I can keep my house totally clean, then I can go out and do whatever I want outside of the house, as long as when I come back in, I engage in all of my rituals and keep my own space clean. So yeah, and I think the really interesting thing is that her goal, she's 39, she really wants to have a family. She is in the process of working on even doing this on her own. And we keep talking about though how, if she were to have a child, whether on her own or with anybody else, that kids are dirty. And we can't prevent them from touching things and bringing it into the house and things like that. And she really understands this. And I think she really feels, and I kind of believe her though, that if she were to get to this point, she would be able to make accommodations and be able to do some of these things, but it's because things haven't really gone her way, that she just, as a way of kind of keeping things clean and controlled, she continues to engage in these behaviors. But then, so interestingly, decided to take a break from Chicago for a month, moved out of state, met a guy. Actually, when she was out of state, she was in New York. She rode the subway once, said never again, but she did it. She is taking public transportation. She's allowing him in her, she met a guy that she's allowing in her rented apartment there, goes to his place. And he is going to move here now for a month. And she told him that she has OCD, and he's really accommodating. And he's like, okay, what do you want me to do to keep your place clean? And she said, I'm not telling you this because I want you to accommodate me. I'm telling you this because things might be hard for me, but I don't want you to accommodate me. So I think within the next few weeks, she is going to be allowing him in the apartment, and not making him change his pants, because she used to have, when her brother would come over pre-COVID, she would make him keep a separate pair of pants at her house and change when he got there. So she's really trying. I don't know how things are going to go, but I mean, that's her motivation for change, and hopefully it'll help, but I'm sure it'll be bumpy and difficult, but it's just really interesting because this is one where it's really just this disgust is so strong. And distress tolerance is very low. Okay. And then, okay. The second one, Kathy, 46-year-old female, mom of 3, has had OCD since she was a teenager, but didn't really receive treatment until her 20s. She grew up in a household where her mom was always concerned about things being neat and clean, like white furniture, couldn't touch anything. Also, like, still sends articles about, like, when they go to Florida, the red algae and how she shouldn't go in the water and things like that. And all of this really exacerbates her own OCD. But interestingly, she's really made a point of, I don't want to be like my mom. So she's almost gone so far in the other direction where, doesn't care what her kids bring in the house or how dirty they make things, because she's really trying to make a concerted effort to be the opposite. Her OCD themes revolve around contamination, decision making, and she did have an eating disorder as well, but that is not an issue anymore. But she sometimes worries a lot about kind of her all or nothing patterns of behavior relating to this. The interesting thing about her is that, she does worry about contracting rabies, ingesting chemicals. If she smells weed, she's worried that that got in her system. What if she takes medicine that wasn't hers? But while she is worried about being contaminated by these stimuli, there is a twist. So it starts off kind of like everybody else, where, okay, I don't want to ingest a chemical because that could make me sick. But for her, it's not even about that. It's about, she's afraid that if she ingests any chemicals, weed, anything like that, it's going to interact with her anxiety medications and make her do something inappropriate. So over the years, we've done, like, caffeine would be something. What if I drink caffeine and it interferes with my medicine and I go and I do something really inappropriate? So we've done exposures to drinking caffeine. During session, she'll take her phone on the phone with me, go into the dispensary, and bring her water bottle in there, bring her purse with gum in there, and then going back in the car and drinking the water and chewing her gum, even though it might have come in contact with marijuana. We've worked on not double checking pill bottles, not asking others about medication interactions. But unfortunately for her too, her OCD is really tricky. And a lot of times the exposures will turn into compulsions. So we have to be really on top of those things. So for example, with the caffeine, she would put a bunch of tea bags in a box and pull one out, not knowing if it was caffeinated or not, and do that exposure. But then it became to whenever she started feeling anxious, she would do the exposure as a means of controlling her anxiety. So we had to pivot in that respect. Another thing we were working on using maybe yes, maybe no as a means of sitting with uncertainty. But then that became actually something that made her feel better. So we want to be really careful because sitting with that uncertainty isn't supposed to be a relief. It's supposed to be tolerating that distress. So once a compulsion or once an exposure starts actually making us feel better, then that's not really an exposure anymore. It's become a compulsion. So we always have to be really mindful of the OCD sometimes being one step ahead of us. And then interesting too, 2 of her 3 kids have OCD and one has like really similar symptoms, even though she's never mentioned anything. She's been so careful not to mention her fears to her kids, but then her one daughter has the exact same fears about rabies, concussions they have fears of, and things like that. So, but sometimes though, it's really helpful that she understands it, but at the same time, then she, a lot of times their OCD becomes intertwined. And then this is something to be mindful of when we're working with OCD is that we never want the OCD to dictate behavior in any direction. So while we don't want to wash our hands or do things because the OCD is telling us to, we don't want to not do it to accommodate the OCD either. So because then that's still being dictated by the OCD. So for her now too, because she's afraid that if she starts washing her hands after certain things, then it's going to become like an all or nothing and she's not going to be able to stop. So now she like doesn't wash her hands after picking up dog poop because of the rabies fear, but she's not really able to look at, okay, when is it okay to wash my hands and when is it not? It's more of like, well, I don't want the OCD to be a problem, so I'm just going to never wash my hands. So in that respect, it's still almost letting the OCD dictate, if that makes sense. So I know it's kind of confusing, but yeah. So anyways, I don't really have any, specific, questions for you guys or for this case, but I just thought it was really interesting. So that's all I have, but if you guys have any questions, thoughts, or any of your own cases or experiences, or if you've noticed kind of some of this trickiness with respect to OCD becoming where the exposures become compulsions and things like that.
Dr. Cohen, if you want to stop sharing, then you'll be able to see everybody's faces a little bit more too. But I would love if anybody has questions about that, of how Dr. Cohen is working with these clients too. If anybody has, what do you do? It's just fascinating. I imagine I have lots of questions. So I imagine people here would have.
Yeah, like very
questions.
rarely do we just come in with these it's people always talk about OCD being like, oh, you don't touch things, and it's like this simple contamination, but very rarely do we ever see these like simple contamination cases where it's just like, oh, I'm afraid I'm gonna get sick, let's just do these exposures, prove I don't, and move on with our day. I feel like it's always a little bit more complicated. So yeah, go ahead, Michelle. Oh, I think you're muted.
Try turning your volume mute and then unmute again. Sometimes that helps. So I can see you're not muted, but I'm not sure why.
Yeah, I didn't think so either, but I can't hear.
Yeah. No. Oh
We could
no.
hear before. That was really strange because we could hear you before.
The volume, try messing with that a little bit too. And if you need to log off and then come back on, we still have a good 5 minutes left. So yeah, sorry, Michelle.
Or if you want to, or if not, put it in the chat and then I can try to answer it that way. Yeah.
It's fascinating too, Dr. Cohen, we've done OCD over the last couple of weeks, but there's so many whether it's comorbidity or just OCD, you talk about harm OCD, just right OCD. I mean, there's so much overlap between all of this. I find it fascinating.
Yeah, it's really, I mean, because, doing some of the white box and stuff too, trying to come up with what are the subtypes. But again, very rarely does anyone just have one. It's just, and it becomes, Yeah, because with the second case where it's like this fear of being contaminated, but then also then doing something inappropriate and causing harm to others. So there's just multiple facets of it. And so it's just not as simple as just let's prove that nothing bad happens. And and she's got every substance. I mean, there's been thousands of substances that she's worried about over the years, and it doesn't generalize. So it's kind of like, this could be the one. What if this is the one that, that interacts and so, okay. Yeah, Michelle, thank you. Yeah, I mean, it is really, that is really difficult. It's, I think with the second case, she really, because 2 of her 3 kids have OCD, and she's really mindful of trying to take a step back and not give well, I think the giving reassurance is really hard, because in her mind, I think she really puts herself in their shoes. She's like, I know I'm gonna I want to make them feel better. Like as a parent, it's always like, I want to help my kid feel better. And so, and she's able to, she's like, well, I know how badly this makes me feel. And so a lot of times there's this even though she knows that she shouldn't give that reassurance, she often will do it because she's putting herself in the kid's shoes too. So it's really trying to help differentiate with okay, with OCD, that if you give reassurance, you're actually now kind of collaborating with that OCD. And so sometimes it's exposure for both of them at the same time. And she has told her kids that they know that she has OCD, but she hasn't gone into detail. So I think it is being honest with kids too, and sharing, I understand and I experienced this, but also not trying to always say, but this is what I would do, or, oh, I understand because I have it too, because sometimes even though the symptoms might be similar, the reason behind it might not be the same. So you might not ever fully understand. So try not to make those assumptions, but also just kind of recognizing when your OCD could be getting in the way. And with the first case, neither parent wants any help at all. Like, they think that it's interesting because I feel like with that family, there's a lot of more kind of OCD mixed in a little bit, because there's this kind of, there's my client has insight, but at the same time, she's like, yeah, I get it, but why doesn't everyone else want to do this? Like, why doesn't why everyone else should be? It's like, I need to tell everybody you should be doing all of these things. But her parents really don't see an issue at all with their own behavior. So.
Thank you, Dr. Cohen. Just quickly, of the show of hands, how many of you guys have OCD clients right now? Or at least one OCD client? Yeah. So clearly just using supervisors, it is definitely the reason why we spend weeks and weeks and weeks on this. And Dr. Cohen's been doing this for years and years and years, and it still continues to be a work in progress. And just knowing that you guys are taking a step in helping them, but there's so much for you to learn as well. So knowing that you can learn from each other, learn from your supervisors, Dr. Cohen is here. It's fascinating, and you won't know everything. So rest assured in that. But I think even just you guys collaborating amongst yourselves, sharing the different clients that you have, what kind of exposures you're doing, sharing the ideas. So thank you, Dr. Cohen, for presenting today.
Yeah. No, it's funny because it's like the things too that you have to be creative. Like the 46-year-old, she's also afraid, well, what if if alcohol interacts with my medication? So I'm like, oh yeah, for homework, go out and drink 3 beer. Like whoever thought that would be homework you're assigning, right? Like, go to the dispensary. Like, and I'm even saying, like, maybe you should even, like, now that it's legal, maybe you should even go, so you don't even have to take it, but maybe even go actually touch one or put it in your purse, even if it's like, what am I doing? Like, what kind of, is this appropriate? I mean, it's so strange, the things that we find ourselves really doing for homework, but it's like, you've got to be creative, because this is, yeah. So it's kind of, I always say, I'm like, I love OCD, and I know that sounds weird, but I do feel like it's something that if you really do the exposures, then there is a really good chance that, it will get better. I mean, we're never going to cure everything, but if we can just get them to engage, and I think that it's really hard sometimes, because why would any of us want to put ourselves in a position of, I mean, we all would choose to avoid things that make us uncomfortable if we could. So it's like, why would I purposely go do something that makes me uncomfortable? So so that's really hard to try to convince them sometimes, but
It's a beautiful way to wrap it up. And Dr. Cohen, even presenting today, thank you so much. Again, this is recorded. If anybody does want to stay on, we'll let you go. I know we're a few minutes, but if anybody does want to stay on, feel free to, and we'll stay on for a few minutes as well if you need anything. And everyone have a great day.
I have a question. Sorry, I
Yeah.
always stay on after. for
Meg
questions.
always wait. Hold on, Meg. I'll continue to record just in case, but Meg stays on with us. She always has a
Yeah.
one-on-one.
no, that's
That is
amazing.
great.
Yeah.
I get
Yeah,
nervous
I
and
love
talking
it.
about everyone. Okay, the last thing you said with like ethical concern or like just like the appropriateness of exposures. I have a question. One of my clients has like contamination OCD surrounding like raw chicken, and she avoids it at all costs to the point where she's vegan, right? Like she won't eat meat in general or like approach it. But she also says there's like she's vegan because of like ethical beliefs and environmental beliefs. So I don't know if you have opinions on how to approach that. Of like, if it is like, I think it's a lot more of avoidance
Yeah.
than ethical concerns, but also that's not really my place to, assume. And so I'm wondering if you have insight on where I go with exposures with that, of like, it's something that causes her distress, but also like having her make and eat chicken is not really a possibility because I
Yeah,
don't want
no.
to cross that boundary.
That's a good. I'm wondering if she'll even though like go to the grocery store and like pick up a package of raw chicken, but she doesn't have to buy it or eat
Okay.
it. So even just like walking by or touching the packaging, things like that, just to be able to, because I guess if there's life interference, right? Like I don't know, because I mean that's the hard thing too. It's kind of like, well, if she's a vegan and she doesn't have any desire to eat chicken and she doesn't want to and she doesn't have to, and then I guess it's kind of like, well, but if I don't know, like, if she would ever have to prepare chicken for somebody, or if she sees it in a grocery store and then has to leave, or she won't like use the checkout line of if someone has raw chicken in front of her, if it gets in the way that way, then I think it's still important to do the exposures, but you don't have to force her to eat it. She could just touch things, because it's already, I mean, I get not wanting to like buy it and cook it and like, but if the chicken's already dead and there, then like she didn't harm it, so she can, so it's like touching it's not, not an ethical concern, but yeah, we don't have to force her to eat it.
Okay, that's helpful, because like it is getting in the way of like if she makes dinner with friends and stuff and she sees them like chicken and sees the chicken and sees it close to the other things in the meal, like she won't eat it, anything. So like I think it is getting in the way. Okay, that's helpful. Just like baby steps with that. Yeah.
Doing that, and then also like when she is making dinner with friends or something, like trying to like, if it's close to the chicken, trying to like slowly do exposures to, can you eat it, or can you like even like have them put a piece of chicken on a plate and then move it to their plate, but you still use that plate or something, so you're not like eating the chicken, but the chicken touched your plate. So I think you could try to be creative with that without force. So you're still getting at the root issue, but you're not forcing her to do anything that she's uncomfortable with.
Okay, that's helpful. Thank you.
Yeah, raw chicken is disgusting.
I know. That's the other